Welcome to Care Transitions Today, Case Conversations, a podcast presented by the Association of Physician Leadership in Case Management and the American Case Management Association, where we dive deep into the world of healthcare case management and transitions of care. Today, we are joined by three physicians, Dr. Rebecca Severe, Dr. Sweta Singh, and Dr. Teresa Jacobs. Dr. Rebecca Severe is a hospital medicine certified physician serving as medical director of care management for Advocate Aurora Health. With a focus on utilization review, quality management, and program leadership, Dr. Severe is passionate about evidence-based medicine and collaborative patient care. Her expertise and commitment make her a valuable asset to the medical community and a compelling voice in the podcast. Dr. Sweta Singh, Medical Director of Case Management at the University of Michigan Medical School, brings a wealth of experience in hospital medicine and a strong focus on quality improvement and patient safety. Her dedication to medical education and commitment to enhancing healthcare make her insights invaluable to listeners eager to learn and grow in the medical field. Dr. Teresa Jacobs is a clinical professor of neurology at the University of Michigan and is a distinguished expert in neurocritical care. Her wealth of experience in teaching and research brings invaluable insights to our discussion surrounding a variety of intricate case scenarios. In this series, we'll explore the challenges and triumphs of real-life case studies, providing valuable insights for healthcare professionals and anyone interested in the intricacies of patient care. Whether you're a seasoned physician advisor, a dedicated case manager, or simply someone passionate about improving healthcare outcomes, Case Conversations is your go-to resource for compelling stories and expert insights. This is Care Transitions Today, Case Conversations. Today we have selected two intriguing cases to discuss.
Thank you very much. Today I have a case for you of a 42-year-old female who has a past medical history significant for migraine, hypopituitary. She also had a pilocytic astrocytoma that had been resected back in 1997. She came into the hospital 2 weeks prior to this admission for a total knee replacement on the right-hand side. So the patient had been at home after this knee replacement, and about 2 weeks after her discharge, fell on a curb. And when she fell, she had a dehiscence of her wound, and it was visible. The hardware was visible at the time of her fall. So she came back into the hospital, and at that time, from the emergency department, orthopedic surgery was consulted. They came to see the patient, and they performed an immediate IND and did a poly exchange of the joint. And the patient whose antibiotics had been on perioperatively were long since over, but the decision was made to place the patient back on IV antibiotics, and the patient was discharged from the hospital. Then what happened was that the patient actually went home, but came back about a week and a half after that, where the dehiscence had occurred. The area was erythematous, it was edematous, and had calor. And she had actually a leukocytosis that had developed, and infectious disease was called to consult on the patient. At that time, it was found that the patient's site had grown Pseudomonas. So I'll leave you with that for information to say, how might you proceed in determining inpatient versus observation for this patient as she comes in for this most recent admission with a worsening area of her knee replacement. Sweta?
This is an interesting case. This poor lady has been in hospital 3 times now, almost within a month. And now coming back, looking at with recent antibiotic, already treated for infection, coming in with the wound dehiscence, and this time the culture. what is the pair we are dealing with? Because if we have Pseudomonas, is the Pseudomonas from this admission?
Actually, the Pseudomonas was from that original IND at the time she had her poly exchange. So this is happening, about 10 days later that she's coming back in because the site isn't getting better. She's feeling more pain. There's edema. It's a hot joint.
Yeah. So again, I'm worried about infection, and as we know, Pseudomonas can be hard to treat. There are limited oral options and high risk of resistance. And this is the third admission, right? So patient has already had good rounds of antibiotic before. So to some degree, failed outpatient therapy. So I would be tempted to start this one as an inpatient and hoping that they do new cultures. We send those work up. Cultures itself will take 24 hours to grow something, 24 hours to speciate, and then 24 to do the sensitivities. So technically 48 to 72 hours. Again, if the infectious disease also thinks this is infected and want to treat it for infection, get the cultures, follow up on the results, and then decide on the antibiotic planning. So from my perspective, I'm already seeing this as at least 3-day hospital stay upfront. What do you
Rebecca,
think?
do you want some more information that I can give you about? We did get an infectious disease consult.
Yeah. I just a couple thoughts even without additional information. And maybe it relates to some of the project work that I focus on lately, but it is the readmissions are just screaming at me right now. I can totally see that the first admission, the second admission, I know within our organization, we're so focused in on that. I feel like I would bound to get some questions like, is there any way we can make this up so it doesn't count as a readmission? Like we have to feel that question just given the focus. And so I would definitely, I'm hearing that in my head. But I'm seeing this as a sick patient. I agree. I think this is a patient where, I'm worried about this knee already. It's been operated on twice. You've got a Pseudomonas species that can be really hard to get off of hardware. I don't think it's going to be a short stay, but I am hearing the voices, from my surgical team asking, for it not to count as a readmission, even my CMO maybe at the site. And I would definitely push, be ready to push back and say, hey, this is the right thing to do for this patient. If they need to be here, we need to just pick the status that's appropriate. And some parents, you are going to get yourself into a readmission denial. It'll be a technical denial for, multiple stays, related to the surgical procedure. But, and you may end up having to roll them all together, which unfortunately is just something I clinically, I don't know how you can avoid it for this one. They're clearly related to the surgery and you have an infection. So those are my initial thoughts, but I guess it's just sensitivities, would be what I want to, be most helpful in really predicting the true length of stay for this patient.
Rebecca, can I ask you a follow-up question on that? You bring up, and I was actually thinking, and initially I thought the question will not be on level of care because it does look like inpatient. It would be, would you combine or not combine these two admissions? And to me, fair enough, they both look related, almost same diagnosis from coding perspective. But at the same time, if they were appropriately treated with the standard of care antibiotic course and had an interim follow-up where they looked and made sure if it's improving or not, and if the culture sensitivity shows resistance, I don't think it's a discharge. It's an inappropriate discharge. And if I would like to combine that, in that case, I might still want to try argue that as a separate admission with more like a reinfection versus resistance that developed and a new infection, not following the traditional course, sort of.
Wouldn't you agree, Sweta, that you would want to say inpatient then if you're thinking that this is combined, because it would be that you combine the inpatient with another inpatient stay, correct?
So I would go for inpatient. Definitely if it's a very gray case where it's a very soft inpatient versus observation, and if it's a combined question, we might opt towards the observation. But this patient clearly looks inpatient. I would go with that first. In terms of combine or not combine, I think we need more information before I can make that determination.
And I can tell you that the infectious disease experts were called in consultation, and they said that this was a PJI, which I had to look up, which is a prosthetic joint infection, with DAIR, which I also had to look up. And DAIR is debridement, antibiotics, irrigation, and retention of the prosthesis. So the infectious disease folks here felt that 12 weeks of IV antibiotics were going to be necessary, which they promoted starting, and they recommended an agent. And weekly CBCs with DIF when the patient is discharged, as well as comprehensive metabolic panels weekly, and to follow up with them in the outpatient setting in 6 weeks. The patient also had some pain, so there was some pain issues, but the pain was treated with orthopedics. They like to keep it PO, and that's exactly how they treated the patient, with PO pain medications, so no IV pain medications were administered. And the patient was discharged on day number 3 because a PICC line had been established and the care management team had set up the home IV antibiotics that were needed. So I guess my question would be, do we have any change of opinion based on what ID had said? Rebecca, I know you were saying you were probably going to get pressure from your ortho folks about the possibility of making an observation, which I can understand too.
Yeah, I mean, I think if it was a question where, maybe the patient was brought in where, the patient was collecting is a little bit red and ortho wants to watch it overnight, we're not sure, those kind of cases, you'll see those. I definitely will pause on, recommending inpatient, with the knowledge that, yes, it'll probably trigger as a readmission. It's likely going to be a short stay, especially if it rolls out. So those I often will tend towards obs on the front end until we are clear. I guess the way this case was painted for me, I wasn't feeling it with one of those. I was worried about this patient. It's already a very complicated patient. And we have the Pseudomonas information. So to me, it seemed like it was appropriate for inpatient. And to me, the readmission cards are just going to fall where they are for, whatever, pair this is. And we'll just have to deal with it. But from being compliant and looking at it medically, to me, it seemed appropriate for inpatient. And did you end up with a denial or?
Yeah, there was a denial. It was discussed in peer-to-peer, but there was no pushback from the payer here whatsoever.
Okay.
They were wondering how it actually got denied to begin with.
Yeah, because I think, and if it was a readmission denial, I mean, sometimes you're just stuck. I mean, you're stuck with the rules of that payer. I don't really see a good argument to say that they aren't related. I mean, sometimes you will try, as what is bringing up, to say, we did our best, especially if you didn't have that information or you had him on antibiotics, it should have been appropriate. And you can say, hey, we had him on good antibiotics, or you can establish the patient wasn't compliant, something you recommended. Sometimes that will help you in a readmission type appeal. And then sometimes you're just stuck having to bill combine. I know our organization doesn't, typically bill combine a readmission unless it's a Medicare product and it happens on the same day. Like they left in the morning and then came back that same day, for the same thing. Those are the scenarios where we'll typically do it. We don't do it unless the payer, has some sort of readmission policy, or we're having to do that. I don't know. Is that how do you deal with that scenario when you do get into a readmission?
So I'll let you go ahead and address that. Our requests to combine sound like there are many more than yours, Rebecca. Sweta, you want to?
Yeah. I was going to add, in this case, I think now that I have IDs input in, and they're using the cultures from previous admissions. So in other words, they think it was undertreated. So I think in this case, because they're not treating it like a separate new infection, but rather retained prosthesis is infected still and needed a long I agree with combining this. In terms of how we address it, we review when we review the case for level of care and CA readmission, we put in, and again, it depends on the pair. Some pairs have a look back period of 14 days. Some pairs have a look back period of 30 days. And if it is, so first we go for level of care, and then depending on the pair, see if it try billing. So we have, let me put it this way. If it is like absolutely readmission combined is appropriate, patient coming back within 3 days from discharge, for example, for same thing, and it was a failed discharge, we will go ahead and combine upfront and send it like a combined case. But if not, then again, based on the pair and based on what the requirements are, we'll go ahead and see how it plays out and then make a determination.
Great. Well, thank you both for joining me in that case. As I said, we won that in peer-to-peer very handily, and hopefully the patient continued to do well on her IV antibiotics. And I think that leaves us to our second case.
The Association of Physician Leadership in Care Management, or APPLCOM, was created to provide support and education for physicians in this field. APPLCOM is unique because of its connection to the American Case Management Association, focusing on the partnership and collaborative model of nurse case managers, social workers, and physicians in care management. ACMA has a rich 25-year history of supporting the case management field. AppleCom is inclusive of all practice settings. Membership in AppleCom also gives you access to all ACMA resources and benefits. Whether you're new to case management or have years of experience, AppleCom membership is valuable. Gain access to professional networking opportunities and resources. Visit www.applecom.org to learn more. Case managers. Join thousands of your peers who have made the decision to further their connections, learning, and knowledge through ACMA membership. Access the Member Education Center with recorded webinars, CEs, and peer-reviewed articles 24/7. Visit www.acma.org/membership to learn more. Let's continue with our second case.
I can go ahead and share a case. So this is a private care patient who is not a 2 midnight care, and it was more of a dilemma on what we call this an inpatient or an observation. So this is a 75-year-old female with a history of relapsed IgG, lambda, multiple myeloma, with disseminated cryptococcus, AFib on apixaban, and she was admitted on for a step-up dosing of, it's one of those new immunotherapies, teclistamab, and CRS monitoring. So what happens is with this particular medication, as per the ICANS, as per the REMS, they need for each and every dose escalation, neurochecks and CRS monitoring for 48 hours before we can do the next dose escalation. This medication itself is sub-Q, so it's given subcutaneously. And before the first dose, we give a dexamethasone 16 milligram, Benadryl 50 milligram, Tylenol 650 milligram, but all oral. And at least then 60 minutes later, we give this injection sub-Q, right? So day one, we did the first dose, and patient got the dose of 3.3 milligram, did the CRS monitoring and ICANS monitoring for the neurochecks. And it requires anywhere from, so generally first couple hours can be frequent checks, and after that reduces down to Q4, then Q6, then Q8 hours. And then patient thankfully tolerated the dose pretty well. So on day 3, it was time for step 2, which is the second dose, 16 milligram, again sub-Q, before that pre-medication given with all oral medication. Patient tolerated this medication well, but required 48 hours of CRS monitoring as well as neurocheck monitoring to make sure they don't develop any neurotoxicity or CRS toxicity. And then day 5, the third dose was given, which is 82 milligram, and followed by, again, 2 days of monitoring. And once tolerated, they were discharged for future doses to be given in an outpatient setting. So by now, this is a 7-day admission. How would you approach this case in both case scenarios? Say this is a Medicare patient with 2 midnight rule versus a private payer patient that does not follow 2 midnight. We are not using any IV pain, any IV medications, no complications happened, other than we are closely monitoring them with the vitals and some neurochecks intermittently.
Yeah, I mean, I guess, for both scenarios, I'm personally thinking, inpatient for both scenarios, just given the duration, the intensity of monitoring, the potential risk of what could happen, even though you clearly pointed out, there wasn't a lot of this IV meds, which makes it's always easier if it's a bunch of IV meds or IV fluids and that, but definitely there's that intensity there. The one thing that, I'm thinking of as I'm hearing the story is, especially for non-Medicare cases is what, prior authorization, for these planned admissions. I think that is key for these. You are going to have a much better chance of getting this through appropriately as inpatient if you ask the payer. If you don't do that on the front end, it's going to be a lot trickier, especially if the patient does well, to get it approved as inpatient after they're here. Now, this one's a pretty long stay. I probably struggle more with the 2-3 day stay cases that are planned for something like this, but this was a long one. So I guess those are my thoughts. I mean, I feel like it's inpatient, but I'm just hearing a few, red flags for me that I'm hoping my team got the prior off. I don't know, Teresa, what are you thinking?
I absolutely agree with you, Rebecca. That was my first thought was, did we get prior off? Please tell me we did, so that we could just say, hey, you guys told us it was okay to come in as an inpatient, because I can't see how this kind of neuro checks, laboratory evaluations, monitoring could be done in an outpatient setting. It just, to me, speaks of severity of illness with risk profile that could not be tolerated in an outpatient setting, even if you had the capability of doing laboratory tests every 8 hours, and I don't know where you're going to get that done. But I definitely feel like this was inpatient for both a 2 midnight payer as well as for a private plan. Again, hoping that we got pre-authorization. Sweta, did we?
So here's the thing. When we requested the pre-authorization, again, some of the payers like to do it their own way, right? They authorize the medication administration, like this medication for the multiple myeloma, but did not specify in terms of this pre-admission. It seemed like it was a relatively rushed admission. And my third question then comes is, so a lot of these immunotherapies, which are relatively new, can be pretty expensive. So in terms of, even if we make them inpatient and have the DRG payment for that, does it still cover the cost of the medication?
Yeah.
So some of these, we like to give them an infusion center, right? Because as an outpatient, you can at least get the medication cost covered now that the medication is covered. So that's where the other part of the dilemma was. Like, in observation, you can bill them as administration of this medication separately, right? So that's why I felt this case was interesting. And yes, we did go for inpatient because of the length of stay. And we did not have the prior authorization, but because the way the payer saw him, basically they just prior authorized the medication and just answered that question, not the admission question.
I know we run into this. I mean, it's not uncommon for us to do that. So one other thing that I'll tend to do in, for these, our high cost medication cases is I will, definitely, I think, reaching out to your pharmacist to find out what is our real cost. And then I personally will partner with someone on our finance side to do some modeling for it, because these are very tricky. And I think, Sweta, you bring up a great point, is that it might be appropriate for inpatient, especially for our Medicare patients. We can't ignore the 2 midnight rule. But for some of our other payers, we really, we have to look at how we are reimbursed for that case and make sure that we're adequately covering our expenses. And sometimes if you have like a cancer diagnosis and you have a, really expensive cancer medication, the DRG payment is going to oftentimes be right sized for that expensive drug. You get into trouble when patients will come in with other, diagnoses. I had a similar case. A patient came in with like a weakness, and ultimately we had to give a super expensive chemo in that, because it was felt that maybe it was driving it. But I partnered with coding, found out how the case was going to code, and it can get really complicated. So I think it's definitely one of I find that these are phone a friend kind of cases where I'm talking to coding, I'm talking to finance to do some predictive modeling on reimbursement, looking at our contract with the payer. But definitely we always make sure we're compliant with whatever we do. So if there is a, Medicare regulation, we, that is, we have to stick with that. Even if we know that maybe we're going to exceed our DRG payment, we sometimes are just stuck with that too. So yeah, that was an interesting twist to it. Did you guys did you do some of that work ahead of time, or did you know how it was going to come out financially?
This is one of the relatively new medications. So we did partner with our pharmacy folks, reached out to find all similar medications that need this 48-hour monitoring, right? Because a lot of times they would come in for this because they need 48 hours. So from the get-go, we know they will need the 2 midnight. So if it's a private here, we try getting prior authorization for the admission. But the other question we had was, if they are getting these medication in the infusion room and then coming in for 48 hours, so we know if they don't have a complication, they will be discharged in 48 hours, right? Even though they would be technically here for 2 midnight. So how do we want to approach that? So that was my other part of this question going to be, this patient comes in next week for the same medication for the dose, gets the dose in the infusion room, and then as per the protocol needs 48 hours of CRS monitoring and gets admitted for that. Again, being a private payer, we'll try to get the prior auth. A lot of the private payers are now getting away. They're not authorizing anything as inpatient. They want to have an admission started and then see and follow and then make a decision. Have you run into those? We have some of the peers now getting away from prior authorization, and they want to see the admission first and get the clinicals and then make a determination.
Yeah, definitely. We're seeing, we have, one pair in particular for us where that is, anything elective is rarely authorized as inpatient, except unless it happens to be an inpatient only, and everything else will be how the case plays out. So I think you're right. That is one thing but I always want to make sure we're asking. I would rather, that is what I teach the auth team, and that's what we build into our standard work is you ask the payer for it. If it's something where we think it's going to be appropriate for inpatient, we ask ahead of time, and we might get no, but we need to make sure we ask. The one thing that it also perked up my ear a little bit as you were describing a scenario that I think is important to be aware of is that we had this happen with one of our cancer clinics that is, again, around a high-cost med, was that they were giving the drug in the clinic, and then they were putting the patient in the hospital. And the reason it got escalated was they were realizing they weren't getting reimbursed for that outpatient encounter in the meds, because you need to be careful of the rule with our Medicare payers that you're going to, those outpatient costs leading up the 3 days prior to the inpatient stay are going to get rolled into your inpatient stay. And so they weren't aware of it. And they've been doing this practice for quite a while. So that's another consideration around these high cost meds. You really have to kind of look at it from a bunch of different angles. And these things can really slip through the cracks if no one's noticing them, no one's asking the question. You at your organization could potentially be losing a lot of money if you're not aware of these, billing nuances and really taking a look at it. Sometimes you have to get really creative, and you have to, like in this case, we had to, partner with the oncology team to say, how else can we do this? And we had some other sites in our organization that had already figured it out, and they would typically give this high cost med, you could actually give it at the end of it. And so that was a better solution for us. It was still, appropriate regimen, but they were not doing it before in the outpatient.
When you say at the end of it, I can think of Neulasta, you can do it that way, but not the chemo medication, right?
The patient would discharge and they would give them, the way the regimen was, they had a window of time and they could have the patient, follow up in the outpatient clinic, after the inpatient stay, instead of giving it on a front end and then, doing an admission for the middle portion of the chemo. They had the opportunity where the regimen, you can do the other part of the chemo on the front end, discharge them, and then they could, come back a day or so later and do the last dose of the expensive medication.
I see. Something like R-CHOP, where you're doing the CHOP part first and the R part at the end, compared to doing the Rituxan in the clinic and then sending the patient for the CHOP, which makes sense. But this kind of medication where you need right after the medication 48 hours of monitoring, I think being aware of that is super helpful, how we play and bill it so that we are not losing money and nobody knows that they've been getting written off or something. Who knows? So partnering and calling friends ahead of time definitely helps. Teresa, you were going to add something.
I was just going to say this is a great case because I think it bespeaks the importance of the physician advisor in being able to reach out throughout their organization to other areas like coding, like billing, like pharmacy, and the different departments on cases like this where you have a question and it really is helpful to have partners working along who have maybe insight that you don't glean right away or don't even know about. Like Rebecca, you said something had been going on for a while without the recognition. So I think the great idea here is that communication is paramount in figuring out some of these more complicated situations, especially as our medications and drugs get more and more advanced.
I think nice to summarize.
Well, thanks, you guys. This was very informative for me. I appreciate always talking with the two of you, and I hope our audience also found it useful, which I'm sure that they will. I'm very excited. Thank you.
Yeah.
Thank you to everyone for joining us for another episode of Case Conversations. We would also like to thank Doctors Severe, Singh, and Jacobs for sharing these interesting cases in this episode. We would love to hear from the audience. Please join in on the conversation by visiting acmaweb.org/podcast, and don't forget to subscribe so you're notified when we upload new episodes. Until next time, this was Care Transitions Today, Case Conversations.